Hi everyone, welcome back to the Thinking Mind podcast. Today we are speaking to Dr. Tennyson Lee. Dr. Lee is a consultant psychiatrist in psychotherapy and general adult psychiatry. He is a psychoanalyst and a member of the Institute of Psychoanalysis. He's also a supervisor in Transference Focused Psychotherapy. At present, he's the clinical lead at the Dean Cross Personality Disorder Service in East London. So today we have a conversation around what the words personality disorder mean, what some of the issues with this diagnosis are, how Dr. Lee thinks about his work with people who have this diagnosis, but also more broadly about what our emotions are, what can happen when we're stressed, and how this can play out in consultations with GPs, psychiatrists, and other mental health professionals. I hope that this is a conversation that can help clinicians think more broadly about their confusing or difficult consultations, and I hope it can go some way to reducing some of the stigma that patients can experience. This is the Thinking Mind podcast. Here you can access in-depth conversations all about psychology, psychiatry, psychotherapy, and self-development. We hope you enjoy. Dr. Lee, welcome to the podcast. Thank you so much for joining us today. I hope that we can talk about this diagnosis of personality disorder. And I hope that we can talk about, the words themselves, the issues with them, and just go through what it means to work with people who come with this diagnosis, the ways in which you think about your work, the things that might be helpful to clinicians, but also perhaps things that might be helpful to our patients themselves. I hope we can talk about some of the psychotherapeutic ideas that underpin the work that you do, and also think about things like medication and what the role of that might be. I guess as a starting point, though, what I always like to do is just get a sense for how people have come to be where they are. And I wonder if you could tell us a bit about your journey to working at the Dean Cross service, to being a medical psychotherapist and a psychiatrist, and what your path to that was like.
It's an interesting question to how we get to where we are. So I was born in apartheid South Africa, and I suppose as someone who's Chinese, growing up in that society, it makes one very intrigued about what's happening in the mind of the other. I think, I was probably sort of, in terms of my background, very much drawn into that curiosity. And then in terms of, again, how the society shapes one, a lot of activist or politically minded young people then went into medicine because it seemed to be the area or an area where one could have an impact. And then, again, although I had an interest in psychiatry, the area that really seemed to be of political relevance was public health. So I initially trained in public health. And then at a time when I'd completed, and in fact was working within a research unit which had direct links with the new National Health Service, which was then a progressive one. This was after the democratic elections. Then for family reasons, I needed to leave South Africa, and then reverted to what was my initial plan to do psychiatry. So I trained in psychiatry at the Maudsley. And again, I suppose what happens is one reverts to some initial thinking. And why personality disorder? I think it's because it's of the patients we see, it's probably the group of patients who in some ways are the most discriminated against. So I think there's something about why I finally ended up working in this area which is both about thinking about the minds of the other. So again, leading to a part of that, what's in the mind of the other, but also my interest in psychiatry. And I am a psychotherapist and a psychoanalyst, but just to say I'm very proud as a psychiatrist. I think psychiatry as discipline has so much to contribute to healthcare, really.
What is the distinction for you there? So when you say that you're trained as a psychotherapist, as a psychoanalyst, and proudly as a psychiatrist, how do you wear those different hats? What does that mean for you?
I think that's a really good point. And in a way, I think that any health worker that is able to think about the interaction with the other, that I think is the important aspect. And what I feel is through my training, I've gained a greater ability to think what is happening in the clinical encounter. So when you say what's the distinction, I'd say, well, in some ways there isn't. If we are in the caring profession, it is about just thinking of ourselves as trying to help the other. And what I've gained through my psychiatric and then psychotherapy and then analytic training is a greater ability to attend to what is happening in the interaction, because the point is that one isn't always clear about what's happening, and it can be very confusing. So what the training does is it just makes it a bit more clear, although I want to be very clear that one still remains feeling very confused in these encounters.
And I think that confusion is something that I really hope we can come to talk to as we build up this idea of your work. I guess to begin, if we even start with terminology and language, where are we at with the words personality disorder? I mean, I increasingly hear the words like complex emotional needs being used. And I wonder if that's a move to try and help with the stigma and the discrimination that you mentioned at the beginning. What do people that you work with want to be referred to? I know that people that I've worked with, the diagnosis of personality disorder feels really unpleasant for them and in a very understandable way. How do you think about this?
I think that's a great question and a very timely one. In fact, Royal College had a meeting last week in which the whole theme was how does one think about the new ICD-11 classification system and its approach to personality disorder. And it was a very complex meeting. I think psychiatrists had very mixed views about it as well. The other point to add is that within my service, we ourselves have thought for years, what do we call ourselves? And at the inception, we thought, do we call ourselves the personality functioning service as opposed to personality disorder service? And I think it's significant that we still haven't changed our name. So we still call ourselves Dean Cross Personality Disorder Service. And one could think of why that is. One of the reasons is just naming something and clarity about what one is, the field that one's working in. So that when I say personality disorder service, at least colleagues and patients have some sense of what the thing is. The point is that if we called ourselves, and I think it's a term that you've mentioned, complex emotional needs. Hopefully this discussion will go into what do we mean by emotions. But if you think of the term complex emotional needs, it's a very broad term, and it's not very clear what the limits are. And one of the roles of us as doctors is to attempt, even though it's very difficult, to have some groupings or categories. Complex emotional needs is a very diffuse category. In fact, one could say, is the category at all? We could think, well, say you and I, are our emotional needs not complex? I think we, just by definition, the nature of being a human being means we're complex animals, really, we're complex mammals. So I think it's a term which understandably attracts a lot of discussion and debate. The point is that if one thought of another term, even if one managed to get one which was more clear than complex emotional needs, part of the problem is the stigma attached to the condition. And so it's likely that the new term would start attracting the same stigma. And therefore there'd be the same question in 10 years' time. Should we change the name, the new name?
So the stigma itself is the thing to work on.
Just something to say to that, and that is when and there's the whole issue of how one discusses the psychological understanding and then diagnosis, and in a very stiff, negotiated way with the patient. But if one does it in a way which is respectful to the patient's narrative and their view of their life, my experience has been that overwhelmingly patients say, "Thank you for giving me the diagnosis. I've thought for years about what is am I struggling with, and I feel held by being informed that what I have is there's description of it, it's known, and there are other people that have similar issues." So, and I think I'm particularly talking about the diagnosis of borderline personality disorder. It doesn't hold for all these specific types this relief that the individual has on receiving a diagnosis. But certainly my overwhelming impression is that with borderline personality disorder, when the clinician discloses the diagnosis in a tactful, caring way, my overwhelming experience has been that patients have been grateful and found that it's been a positive piece of information to hear.
How do you do that? And I get the sense that it may not even be something that happens within a single consultation. But how do you explain it in a way that is respectful and acceptable to them?
I'm really glad that you've identified it. It's not in a single consultation. And that's such an important point for clinicians to keep in mind, that one builds the understanding not over one meeting. The way that I do it is, I think I'm helped by two aspects. The one is the recent evidence emerging about how the brain is wired, really. And that is a real acknowledgement that all of us have basic emotional needs. Now, for example, one of those needs is the need for anger or aggression. If there is something or someone who is presenting an obstacle to what we want, then we feel anger. Now, this is so important to realize, because if the individual says, "Doctor, please help me, I don't want to be angry," if one has a clear understanding and manages to convey even just a bit that feeling angry is the human condition, how angry one is and what one does with the anger, with the emotion, that's another aspect. But just the emotion of anger in itself it serves a function. It's partly what is necessary for survival. So that's the one aspect, just the stance of the clinician to think about the patient coming in and describing emotions that they have and saying, "Please take it away." So it's that sense of, that isn't where the intervention really lies, taking away the symptom. But the second is being able to hear the patient's narrative and being able to hear in a way which is discerning. Because when our patients come to us, they come with the emotions. They say, "I feel sad," or "I feel lonely." The discerning way to listen is to think about, what do you do with that emotion? because within that lies the difficulty. In other words, there's a certain emotion which kicks off a pattern of behavior. Now, if the clinician can talk with the patient in a way which starts uncovering what the pattern of behavior is based on the very unwanted, unpleasant emotions that the individual has, then you start developing a narrative. So, for example, the narrative could be that what you've described is wanting your boyfriend to love you, and you want to be sure that he's not going to leave you. And that's a very important aspect that you described. And I would do something like say, and of course, that's what we as human beings, we want to be sure that the person that we love loves us in return. So I try to build a shared understanding of that emotion. Then what I'll get on to, and this is where the skill in the clinician is required, because by the time, and what I'm doing is showing my formulation. So this, as you've indicated, it doesn't happen in meeting number one. It requires a few meetings just to get this understanding. What I'll then say is, and because you are understandably anxious at times, what you've said you do is that you text your boyfriend 30 times in an hour when you don't know where he is. And at times you've been so concerned about who he's with that you've said to him, switch on the video on your phone so that I know where you are. Now, the reason why I'm saying that to the patient is I'm trying to give them a sense that those very understandable behaviors due to in this case, the patient's concerned about being abandoned by her boyfriend, that those behavior patterns are not developmental. In fact, they're destructive. So that's how I try to share the discussion or the understanding with the patient, so that we can get a shared formulation or understanding of what might be the anxiety and what might the individual do to try to reduce that anxiety, and can they see that in fact it's not working. So that would be a way to have this discussion, so that it's not, but it's a shared discussion, because it would need to be the patient saying, oh, and I track my boyfriend. Then I use the patient's words. So it's not me coming up from some high position saying this is what, it's actually using the patient's narrative. But I think the skill is in using the patient's narrative, but changing the positioning of those coordinates so that one makes more clear to the individual, this is what you are doing. I think that's the skill which is useful in the meeting with the patient.
And this is perhaps a slightly off-field question, but I am aware, I guess in psychiatry, as I've seen it so far in my training, the chance of a psychiatrist having multiple meetings with someone like that, unless it's on a ward, is probably fairly slim. But I guess I can think of other clinicians like GPs who, again, I think in the modern NHS there is less continuity of care, but potentially have more chance to bring people back, or maybe bringing people back. I guess how could people adjust in those different situations, do you think?
One of the points that I make when I speak to GPs is to, first of all, to anticipate that the patient that you see might have a personality disorder. And the anticipation can occur through the reception of saying, oh my word, I just had this very difficult phone call. In other words, there may be advanced information which will help the GP. If there is, then, and if it's possible within the scheduling of the appointments, I would think it's worthwhile having just a bit of a longer time, so even if it's half an hour, to meet with the patient. And I think the main point I'd make to the GP is, and it links back to what we've said earlier, that it will take a very long time because the patient is hardwired into responding in particular ways to the stressor. For the GP to realize that it's not going to be sorted in the first meeting, and in fact, not even to place upon him or herself as the GP the expectation they will understand. If they can enter the meeting just with that sense that it's going to be a confusing meeting, that they may feel lost in it, and that the patient will probably not feel satisfied. If they can go in with that sense of that's what may happen, and it's not because I'm a rotten clinician, I think that's very important, because it's often the technical point for clinicians is that it's often a very difficult encounter. And then it's for us to think as health professionals, how do we respond to difficult encounter? And it's that needs to be managed. So that even if the patient leaves still feeling, you haven't helped me, I'm still got the same question, and what are you doing about my medication? Because you haven't been very clear. If they can just have the experience of being with a clinician who has tried to listen to them, not feel pressured into rushing into a decision, that in itself has some effect which is probably more beneficial than being overly organized by the patient in terms of the pressures, because that's what patients with personality disorder manage to do at times. They manage to organize the doctor or the clinician to do things that he or she wouldn't normally do because of the extreme pressure of the encounter.
And from the patient's perspective, they're going into the GP consultation, again, they might be feeling unsatisfied or expressing that they're dissatisfied. What's happening from their perspective, do you think?
I think that's a really important point, because if one can just think exactly your question, because if one thinks of what might have been the early experience of that individual, in other words, if they've had an early history of a parent that is either neglectful, absent, or at times just abusive, the child develops an expectation that is how others relate to them. And that expectation then continues into adulthood. So the patient who comes, and they come in, and it's a busy reception room, and the receptionist is busy, and there's a queue of 6 people already waiting to see the receptionist. And when they so they're already a bit anxious, and they're sort of sussing out what's the receptionist like, and so, oh, this receptionist doesn't give very much eye contact. When they get to the front, the receptionist might say, how can I help you? And, slightly rushed away because the receptionist is very busy. And if, for example, the receptionist doesn't give eye contact, all of those you can see, because the patient has been primed from early experience to expect an unfriendly, unhelpful response, it already gets them to be more anxious. And when we get anxious, we can at times become aggressive. So I think that the earlier experience of the patient both informs how they experience present experiences. That's the definition of the transference. In other words, the patient is being influenced by past experience in the present. So they experience something which is happening in the moment due to their earlier experience. What I wanted to add to that is one can then see, in a way, the real, and maybe it's oversaying, but I think it is a tragedy, that what happens is that the individual predicts a unwelcome response. Because they predict it, they may behave in a way which actually elicits that unwelcome response. And that's what makes it so difficult for some individuals, that because they have this inner template of an unfriendly, unwelcome world, and they, in a way, bristle up in advance as an understandable defense to what they think will be an unfriendly reception, that they finally elicit that. So their prediction actually elicits what actually happens. And that's really very, very difficult. But in a way, if clinicians can keep in mind why might the individual be doing what they do, and again, I think it links to your earlier question that the information or that the consultation doesn't happen in one. Because if one is able to get some early history, it really helps the clinician to have greater empathy and sympathy for the patient. At times when there've been very difficult encounters, and then you hear about just how frankly horrible at times the patient's early experience has been. It really allows the clinician to have greater empathy.
And are you thinking about that specifically again within this GP consultation, or actually ideally within, even if it's a psychiatric assessment, that ideally you would try to not rush into areas that are going to be very, very difficult?
So I would say whether it's a primary care or secondary care encounter, that one needs to have the same degree of tact and carefulness in terms of eliciting the early history. One issue which I think is a really important one, and this comes up repeatedly when I do violent groups with psychiatry trainings, and that is I very much encourage clinicians to think of the setting and therefore the task of that encounter. The reason why I'm saying this is that my experience has been that I think particularly younger colleagues who, have this real zeal and wonderful wish to help our patients, they might lose sight of what the context and therefore the task is, and move into what almost seems to be a psychotherapy mode in what is an assessment. And I think that is not recommend practice. One, because the clinician in an acute setting may not see that patient again. The patient is aroused anyway, and therefore the ability to have a therapeutic intervention is, I would say, very, very low. And therefore, it's really important, if it goes back to what level of detail is required, I think then to think what level of detail is required for this particular meeting with this patient at this stage of contact with the particular service that I'm in, and what role will I have or not in ongoing. So I think it's very important to keep all of those in mind, because it can be very inviting for the clinician to go down the path of either getting more and more information or of saying or doing something which the clinician thinks is therapeutic, but often is not.
Could you give any examples, do you think? Or is there anything that comes to mind when you say that the clinicians can say things that they think are therapeutic, but actually, for instance, in an acute setting, could potentially really not be?
The ones that spring to mind are when trainee psychiatrists in the Berlin group talk about an assessment that they did at 4:00 in the morning in A&E. And it's often with a quite a young patient. And that what emerges is that they, in fact, this happened last week, that they've spent a long time on the assessment, on the history taking, both present context and early history. And even if not going into straight, clear psychotherapy, really giving the patient a sense of their understanding of how difficult it has been for the patient. And what happened in this encounter is that when the psychiatry trainee was trying to wind up the consultation, the patient started giving more and more information and started saying, will you be the ongoing person I see? What's going to happen now? Now, all of that might have happened even if the trainee had been more able to think about what the task is. But I think the issue is that because our patients, and it goes back to the basic emotional systems, they want to attach, they want to find a doctor that they think is understanding and interested. So that's an example of the need to think about setting and task. And for example, when the patient might want to go into a lot of detail about something, for the clinician to have tact and say something like, what you're saying now is clearly so important. And clearly I can see that there are links to what's happening for you now in terms of what you've said. But unfortunately for this meeting, we will have limited time. And for me to really be able to help in this present setting, I think I'm going to need to ask you to some other questions. In other words, it's tact, but to not dwell. And then again, it's the ability of the clinician to know what is the main function of the meeting and to gatekeep. In other words, again, the distinction between an assessment and a therapy setting is that at times in the assessment, the clinician might need to be more active. They might need to control the interaction more, but clearly not in a heavy-handed way. Clearly, one has to use tact all the time.
And something that I'm curious, and I'd like to go back to something you said much earlier, was around this sense that can arise, or this thing that can arise where through a patient's expectation or preparation for how an encounter might go, they can elicit a response that actually confirms that prediction. And again, how do patients experience that? How does that happen? Because I think our patients often come to us saying, I have had these terrible experiences in healthcare, and you listen to it and it does sound like indeed they have at times been treated in ways that shouldn't have happened. How does that happen? I guess in a psychological sense, if we assume that most clinicians are not actively trying to harm their patients.
I would be very cautious about giving the patient any sense that I'm not taking in what they say as the early experience of services as valid. I'd be very careful about it. I'm not saying that I would then say it's all valid. So a way that I would try to manage that is to, again, it links to the discussion we had earlier. I'd be thinking, how might that past experience relate to the present? And so therefore, if it makes sense in terms of the dynamic of the encounter and what the patient's saying, what I might be more willing to consider saying is something like, given this experience that you've had of services where you found them so unhelpful, I think you may be anticipating that I'm going to be yet another psychiatrist who's going to be unhelpful. In other words, can you see, I'm not saying your previous experience is not accurate. I'm accepting that's their subjective experience of previous encounters. I'm giving what is an analyst-centered interpretation. I'm saying, I think this is how you might experience me, or might be anxious about me. And by doing it in that way, I'm allowing the patient's projection into me to be stated, but I'm not saying, and you are doing this to me, you're projecting this anxiety into me. I'm just saying, this is how you might experience it. And the analyst-centered or the therapist-centered interpretation might allow the patient to have at least some sense of being at least a bit understood. So you can see that I'm saying I haven't answered your question directly. It's a bit of a sideways response. And I don't know if you want to follow that one up, if you want to say no, you want to pursue the other one because it's not being adequately answered.
No, I think that gives me a sense. But yes, I guess I wonder if you could say more about the in the moment eliciting of a response that can happen, or even, again, something that you touched on about a clinician feeling pulled to do something out of the ordinary in their practice. And I guess, again, my context, I guess, for asking this question is also how do we think about it in a way that doesn't, I presume, in a way that doesn't blame. It's, it's not saying that this is I think you often hear words like manipulative being used with patients, which always feels unkind and, I imagine, unfair. But I guess it refers to something that's happening in that encounter.
That point you make about manipulative, I think, is a really very important one, because, again, I think a way to think about it is that we should think about personality as a dimensional construct. The reason why I'm saying that is that you organized this interview with me. Is that manipulation? And we would say, well, don't think so. I mean, you asked in a very kindly, tactful way and made me feel, yes, I would like to participate. But you have organized me into this interview, which is what life is about. Our life is about negotiating our way and doing the tasks and things that we feel we want to do that are important. What's the distinction between inviting, organizing, and manipulation? The distinction might be in how desperate the need is that needs to be met, and the way in which the individual tries to organize. So I think if one thinks in that way, again, that might allow some empathy and sympathy, that if a clinician feels I'm really being manipulated, to think, what is it in the service of? And then it goes back to the emotional systems. If in fact the patient says it's unacceptable that you are ending this meeting in half an hour. I want at least an hour of your time. Now, they might be saying it in exactly that way of being very demanding. But if one can think, what is this in the service of? It's in the service of the patient wanting to spend more time with me because they're wanting to deepen the attachment to me. Then one can start thinking of personality in the round and not just as a personality disorder, so that one can then view what seems to be, a patient, for example, says, and if you don't do it, I'm going to go out and harm myself. Again, one can think that all of this is in the service of trying to organize the other. It's being done in a very crude way, but it is with the same function. So I think that's one way to think about, and I think it's a very important point that, and maybe, one of the points that you raised earlier and I think it's not just for GP colleagues, I think it's for psychiatrists or any mental health professional, and that is, it's very useful to think that, is the person that I'm seeing, does this person have a personality disorder? Because sometimes it's not always clear, and for example, and I think again with your GP colleagues, this would be a great discussion to have about how patients might somatize or just come with other symptoms or complaints, but they never go away. That might be an indication that there's another aspect present. The point I wanted to make is that if one gets the sense of being manipulated, that might be a clue that you're working with someone that might have a personality disorder. In other words, it's the crudeness of the attempt to organize the other. And then how do you know you're being manipulated? If you get a tinge of feeling irritated. None of us like being manipulated. And the clue, the clue that we get, that our body sends to us is, oh, I feel a bit irritated. So again, colleagues, if you, or to the clinicians who are listening to this podcast, if you start feeling irritated, then it's very interesting to think, what's irritating me? Because it might be a clue that you are working with someone that might have a personality disorder.
And I guess the point that runs alongside that is how you react to that irritation, and through developing a sense of being able to notice it in yourself, it might give you an ability to choose what action you take, and for that to hopefully then be a compassionate.
I'm so glad that you come back to that, because I do a teaching on the application of Transference Focused Psychotherapy to general adult psychiatrists. And the teaching takes place over 6 hours. It's a set workshop. The main message that I get across, if psychiatrists come out of the workshop with these two main messages, then I feel very content. And that is one, that it's okay to feel utterly confused in the interaction with your patient. And two, and it's so tightly linked to that, is it's then important to not act out. Now, when I say to not act out, I suppose we can all think the not act out as in not display irritation. But in fact, the not act out is also the ability, and it goes back to point one, it's okay to be confused. You may have very little idea of what to do. Now, for us as clinicians, it's galling to not know what to do. But if one can just accept that is the countertransference, that is the experience of being in the room, at times the patient who has a personality disorder, that already gives you some breathing space to say, I don't know what to do. I'm feeling really confused. I'm feeling irritated. I'm feeling completely out of my depth. And then to say, and that's okay, because that's the nature of the encounter. Because it's not just the acting out isn't, so just to define acting out, The technical definition of acting out is it's the replacement of thinking or feeling via behavior. And I think it was one of the areas that you were interested in, which is what leads doctors to prescribe, particularly what leads doctors to prescribe when there's no research evidence for the benefit of using a particular medication for a particular condition. And here I'm thinking of borderline personality disorder, where there's no accepted large trials which show any evidence for the effectiveness of medications. And if we think of over 90% of our patients with borderline personality disorder are on psychiatric medications. Can you see my point about the acting out? In other words, why does the psychiatrist or the GP prescribe medications for a condition where there's very little evidence that it's helpful? So it's not just the acting out in irritation, it's the acting out in the service of trying to help.
And let me take you further on that question. I mean, what is the role of prescribing in people with personality disorders, or what can be helpful, but also what, or maybe when can it be helpful, but also what else can be happening, or what else can be the meaning of the prescribing that can be happening in times when it's actually not helpful?
Again, I think it's a very important question, and I'll probably go back to what I said earlier about what does the psychiatrist need to keep in mind at 4 o'clock in the morning in an A&E setting, and that is to think about the context, it's the frame and what the task is. In terms of thinking about the use of medication, the reason why I said frame is if one accepts the NICE guidelines as a frame, and what the NICE guidelines state very clearly, these are the NICE guidelines on medication for borderline personality disorder. What the NICE guidelines state very clearly is that there is no indication for the use of psychotropic medication for the symptoms of borderline personality disorder. What they clearly say is that there's a role if one has, for example, a depression is diagnosed by a doctor, then there is a role for use of antidepressants. The only indications that they say there's a role for treatment of symptoms is at times for sleep, where one can use hypnotics, or if the patient is very agitated, to use antihistamines. Those are the only two medications. Now, the point I'm making is that if one has a set of guidelines that one accepts, and I'll just say that one would need to make that decision to accept the NICE guidelines, and based on the evidence, and there's been ongoing Cochrane trials, I would recommend to clinicians, if you're not following NICE guidelines, think of what your countertransference is. What may be reasons why you are reaching out, to write a script, and then if you are, for example, prescribing, say, an antipsychotic for a patient where your diagnosis is borderline personality disorder, then it allows you to think of your countertransference. In other words, how does one know one is acting out? In other words, the acting out could be unconscious. That's why it's so important to know how do you normally work? And if the way you normally work is to not use psychotropics unnecessarily, then if you catch yourself that you are, that's the clue that there might be some pressure that the patient or the situation is bringing to bear on you, which is leading you to not follow your normal practice. I think the main point I'd like to get across is that if we think of the brain and the different functions of the different parts of the brain, then we can have utter respect for all the different modalities, whether it's CBT, cognitive behavioral therapy, or dialectical behavioral therapy, or mentalization-based treatment, or transference focused psychotherapy, or psychoanalysis. Because if one accurately thinks about what the different functions of the brain are, then one can start thinking, which area is this particular modality most targeting? I think that might be, a way to think about the different ways that one can think about therapy regarding personality or personality disorder.
Because as far as guidelines go, that would be the mainstay of therapy. If your diagnosis is something like borderline personality disorder, then you should be trying to direct that person's treatment plan in a way that includes psychotherapy.
It's a yes, and then a footnote to the yes, because it makes absolute sense what you're saying. If there is, and there is an evidence base for the effective treatment of borderline personality disorder through, for example, dialectic behavioral therapy, mentalization-based treatment, or transference focused psychotherapy, then what you've said makes absolute sense, that one would, as a clinician, want to direct the patient towards those therapies. The issue, though, is that even in patients that have severe presentations of borderline personality disorder, they may not be at a stage where they either are able to use the intervention or want to use it. So it's not just the diagnosis or the level of severity, it's also which stage is the patient at in terms of being able to make use of an intervention.
And my final question, what do you do when they're not ready?
That's such a good question.
And I guess again, I'm maybe thinking from the perspective of either a GP or a community team care coordinator who are holding people who come to them regularly feeling all kinds of overwhelming things. How do they manage that?
The number of responses or to your question, the one is, how do you maintain a sense of hope if you've had a very, very difficult encounter, or if the patient has no sense of hope? What I've often found is that there's one GP in the practice that is prepared to see patients with personality disorder, and that GP becomes the go-to person. And I think it's so important in practices that there's a practice-based approach to personality disorder, but also if there are particular individuals that have particular talents or willingness to work with patients with this condition, that is absolutely built into the GP practice system. So it's not just the individual then keeps on having to sort out things on their own. That's the one. The other is, I think there's a real role in the GP practice having good contact with the psychiatric service, or if there is one in the area, specialist personality disorder team. Because I think the psychiatric service or the specialist personality disorder service, if it's worth its salt, will absolutely recognize the role that primary care is playing. And even if the patient isn't ready, and goes back to your question about what would the intervention be, even if the patient isn't ready at that point in time, for therapy from a specialist service, that the GP practice has the benefit of thinking with colleagues who are working with patients with this condition, so that finally it becomes a system issue. It's not just primary care, but it's how does secondary care think with the primary care colleagues about this particular patient, and how could they think about the bridging, what is required? Because what's so important is, and again, it's the installation of hope, that if one can say, both to the patient and to the practice, that these are the areas which would be important to put in place, for example, stable accommodation. And I appreciate that in itself is a huge issue. Or, for example, problematic or dependent alcohol use. These are the areas which need to be put in place And we are very interested in working with you further, but if those can be addressed. So I think my response is to think about it within a system because, and again, it goes into, I suppose, in a way, your interest in the topic. We're talking about personality. Personality isn't just it doesn't just link to health or to mental health services. It goes into many, many different areas of one's life. And so that if we as working within the health system can coordinate at least within the different levels, I think that models the need for thinking about personality in a far broader context of how are we as individuals in society.
Dr. Lee, thank you. As I draw us to a close, I wonder if there's anything in your mind that I haven't asked you about specifically today, or anything else that you would want to get across in this particular episode.
No, I mean, clearly there's so much more because the topic itself is so fascinating, and you've touched on the issue of narcissism, which I think is a very important one for us to be thinking about. But I can't think of anything specific, and just to thank you, I think that the way that you've addressed these questions is very broad, and I think it's allowed us to get into the richness of the subject, really.
Thank you. Is there anywhere else, if people want to find out about your work, anywhere else that they can find you? Or
and then there's also the DeanCross website, which people will find if you look up DeanCross and East London Foundation Trust.
Fantastic. Dr. Lee, thank you so much for joining us, and hopefully we'll see you again.
Thank you. Bye.